thank you everyone for joining today to GAP, the MASLD MASH Community Network. We will today be maybe gonna make me do it like that. Maybe there's a delay. Hold on, I don't. Okay, I'll just try it this way. All right, so we're going to be talking today about non-invasive testing. Um, uh, Real quick, Christine, I just wanted to see, are we recording yet or?
Yes, we are recording. You're
Okay,
all set.
fantastic. So, listen, I'm happy to field questions. I know that Christine is monitoring the chat. If you want to put questions there or answers there, or also shout things out, I love getting interrupted because it gets me telling really fun stories about patients um, and it's pretty easy to do. So feel free to interrupt and ask questions at any time. Again, non-invasive testing, which I will say that this is a relatively new thing in the world of hepatology. When I first got into the field 15-ish years ago, it was basically biopsy or bust. And I'm so glad that we have the opportunity now for patients to get a good assessment of the status and health of their liver without getting a really painful needle and procedure done. So thank you, science, for making that happen. Again, my name is Janet Gripshover. I'm a nurse practitioner by training, currently at Cedars-Sinai in Los Angeles, and I love it here. Okay. Make sure that you get credit for today's meeting. Here is a QR code. I will give people a few seconds to get a grid screenshot of that and again, record your attendance today. And if anything I said interests you regarding the MASLD MASH Community Network, you can go ahead and visit that website where there's lots of fantastic talks just like this one by some of my best friends and colleagues in the world of liver disease and regarding MASH disease state education and Madrigal branded information on Resdifra. Okay. And with that, let's go ahead and jump right into a case study. So, real fast, I'd like to talk about Albert, who is a 65-year-old male. He has obesity and is referred to the clinic for elevated liver enzymes, and he has an abdominal ultrasound that is remarkable for increased echogenicities consistent with steatosis. So, basically, it's not uncommon for primary care when they see elevated liver enzymes, they want to get a picture of the liver with an ultrasound. And what the ultrasound is really showing is that the texture of the liver isn't very even. That can happen from a lot of different things. Fat's a very common thing, but also scar tissue can be a very common reason for having that increased echogenicity. So you were fortunate enough to get some labs on this gentleman, and he's got some triglycerides. He's got an HDL that is actually pretty good. His hemoglobin A1C has seen some better days, and his ALT has known elevation for the past 3 years. And another thing about when we talk about elevated liver enzymes, we typically try to talk about it in degrees or multiples of the upper limit of normal. As a reference point in the back of my head, I've always kind of um, held that upper limit of normal for AST and ALT around 40. Now there's some data out there that's saying it should be probably be a little bit lower, but 40 is a good ballpark place to consider when you're talking about multiples. So we know from this data that his ALT is probably ranged somewhere between 40 and 80 over the past 3 years. And his evaluation of other liver diseases are negative. Um, Alcohol history, so important when we're talking about how we're going to assess a liver patient. And for Albert, he's had no alcohol since his 20s, which is amazing and fantastic. It sounds like he's been listening to his diabetes provider by not drinking any alcohol. He does have the trifecta of type 2 diabetes, hypertension, and hyperlipidemia. And on exam, you see that he's pretty much a typical dad bod. He's got this abdominal adiposity, but he doesn't have any stigmata of advanced liver disease. And by that, we usually mean things like spider angiomas or palmar erythema that we typically see in patients who have advanced liver disease. And his BMI is 29. So again, he's not fit, but he's not technically obese. Right. And maybe this slide will advance. Oh, I lost control. That's why. Here we go. So diagnosis based on all of this. Because he has no alcohol on his history and his evaluation of his other causes of chronic liver disease are negative, we can assume that he's got metabolic dysfunction-associated steatotic liver disease. So again, we see the fat in the ultrasound, or the likelihood that it could be fat in the ultrasound. He's got the known medical history for it. He's got the lack of alcohol and a lack of other diagnoses. Those are the 5 things that you need to establish that diagnosis. All right. So the next question that we have when somebody has fatty liver disease is, well, how bad is it? And here is where the crux of this talk is going to be the non-invasive assessment of liver disease in 2025. And it's important that we identify which year it is because there could be a very good chance that next year at this time, this slide will be completely different. But some of the things to think about is that we've got these imaging biomarkers. So we've got ultrasound quantitative techniques to identify liver fat. We've got MR capabilities of identifying fat and the CAP score. We've got imaging biomarkers. So that's going to be your shear wave elastography, the vibration controlled transient elastography, also known as FibroScan in the United States. We have MRE as well. Again, MR elastography. We've got clinical predictive calculations that we can do, like the FIB-4 or MASLD fibrosis score, or APRI. We've got proprietary serum markers for fibrosis, so things like FibroSpect or the ELF score. And then the best ones of these, in my opinion, because of their increased sensitivity and specificity, if I can get it to pull up, is the combined rules. So this is basically where we take 2 different modalities. So like a FIB-4 and a FibroScan or something like that. And we combine the 2 results together to get a highly specific, highly sensitive test that we can pretty much rely on. And the reason why this is all so fantastic. Not only do people not get a needle in their side, which again, nobody loves to have, but also, we can get a good predictor of what status that their liver is right now. And, we can use this to identify treatment modalities and figure something out before a patient develops symptoms and before they develop irreversible liver damage. So these tests are repeatable. They have, again, really good predictive and sensitivity numbers. So it's, again, these are really fantastic things to use in practice, and again, make clinical decisions based off of it. All right. This is my favorite test ever in the whole wide world. It's called the FIB-4. It's a great, quick and dirty for figuring out what the likelihood of having no fibrosis or cirrhosis. Okay, there are 3 different classifications, and as you can see, it's a pretty simple test. You can use off of basic labs with age, AST, platelet count, and ALT. Yes, you'll probably have to do an internet search for a calculator for it because it's not one that you can do in your head. And if you can, you're probably in the wrong field. But basically, if you have a low FIB-4 score, it's almost certainly not cirrhosis. If you have a high FIB-4, it could very well be cirrhosis. And if you're somewhere in the middle, then you need to do probably some more testing to figure out what the heck is actually going on. So it's a really good way to figure out which ballpark that we're going to be playing in. The ELF, again, is a proprietary serum marker that if you have been in the field for a long time and you remember FibroSure tests, it's very similar to that, where the idea is that they're using a whole bunch of serum biomarkers and doing fancy calculations with them to figure out how much damage that there is in the liver. And by damage, we mean scar tissue and scarring, because as we remember about the scale of scar tissue is that you can have no fibrosis all the way to cirrhosis. And we're trying to figure out where on that pathway the patient is. So with the ELF, if you have a lower score on the ELF score, it's less likely to be cirrhotic. And if you have a higher score, you're more likely to be cirrhotic. And there are these cut points for, like again, a stage 2, where a cut point of around, I want to say like 9.5, or it says cut point of 9, you have 60% specificity and 85% sensitivity of having advanced fibrosis. And again, when we talk about this, we're trying to identify what is your risk for getting worse and risk for having cirrhosis, and do we need to do all the cirrhosis screening and cirrhosis testing, and start thinking about how to best protect the patient moving forward. So those are the two blood biomarker tests that we have. Moving on, now we're talking about liver stiffness measurement. So liver stiffness is a really, really cool technology where we're basically measuring how much scar tissue a patient has. So scar tissue is stiff. It's not flexible. It doesn't really squish very well, as where a healthy liver is going to be kind of squishy and malleable. A cirrhotic liver is going to be a lot harder and stiffer. So if you think about that, and you send a sound wave through that, and that's basically for either transient elastography or MR elastography. They're just slightly different kinds of waves. Where transient elastography, basically you're checking how wiggly the liver is by sending a sound wave through, and you're measuring how hard and fast it bounces back. With MR elastography, you're sending a sound wave and you're measuring the degree of waves that you're getting off of the liver. So those are the kind of the difference of the two different tests there. And again, generally speaking, the stiffness score will increase with how fibrotic the liver is. So again, a stiffer liver is not going to be as wiggly, or it's going to be stiffer. It's going to be harder, and sound waves are going to travel better through it, um, uh, leading to the higher scores. There we go. Okay. So this is the most common one used in the United States. This is vibration controlled transient elastography. Brand name is FibroScan. And again, it's a non-invasive quantification of the two physical biomarkers of the liver. And basically you get a measure of liver stiffness, which is again that sound wave, how hard and fast it bounces back to you after you send a wave at the liver. And then there's the CAP score, which is a measure of steatosis, or it correlates with steatosis. That's, again, it's obtained with the measurement. You get kind of both at the same time. And again, we can use both of these scores to get a sense for when people do have metabolic associated steatohepatitis, what are the next steps and what are the next things that you need to do. So some things about the FibroScan. This is a lovely FibroScan picture, and I don't know if I could ever get a liver stiffness test that is probably this clean, because this is one of the cleanest I've seen. But basically, you want to make sure is that when you're doing the reading, you're trying to keep the wave consistent when you're getting it, and you zap it to send the pulse back, or to send it out and back. What you're looking for are at least 10 valid measurements that are coming back that the machine reads as an accurate test, or that it's coming back clearly to you. Things like, and the machine can tell, like if you're zapping like a slightly different part of the liver, or if it's bouncing off of a rib or something along the lines of that can impact your reading. And what you're looking for is a bunch of readings that are within a narrow range, because you're going to get, when you do this test, you're going to get like one at 7.1, and the next one might be 10.3, and then you're going to get an 8.4, and then it's going to measure all of these things and kind of come up with the average of them. So if you have a wide dispersion of different test readings, and it's probably not going to be very accurate. But if you get a more narrow dispersion, then it's likely that you're getting an accurate reading. And that's what we're talking about, the interquartile range, is that you're looking for that median 50% of readings within a narrow range. So if that narrow range of readings are basically usually within 30%, then, and the liver stiffness is high, then you can get an assessment that, yeah, there's probably a more fibrotic liver than not. Looking at again, you look at the quality of this beautiful, beautiful clean line here that kind of goes down. This is basically showing you that shear wave. And then, how many measurements did it take you to get 10 clean ones? And there's also some studies out there saying too that the more that you do them, the better you get. I mean, I know that's like completely jaw dropping for everybody on the line. The more you do something, the better you get. But if you're just learning how to do it, you're more likely to get a wider dispersion and your results are not going to be as accurate as somebody who's done them for the past 10 years. Other things to consider. So remember, this is measuring stiffness. So anything that could make the liver stiffer and possibly even temporarily so can really mess up your readings. Now, things like if you've got a lot of swelling in your liver, like your liver enzymes are elevated, that's a marker of the liver being aggravated. And so an aggravated liver can be a little bit swollen. So if you've got high ALT or AST, that could affect the reading and can make it look more stiff than it actually is. If you've got cholestasis, again, increased bile in the liver is going to make it more stiff. When you eat, one of the things that happens is that your blood rushes to your liver because it says, oh my gosh, oh goody goody, we've got nutrition coming, let's go and digest it. So after you eat, you get a big rush of blood to the liver, that can make it stiffer. Alcohol, inflammation, and the rush of blood. Obesity, if you have a really high BMI, remember what we're doing is that we're sending a sound wave down to the liver and watching how fast it comes back. And if you've got an inch or two of adipose tissue in between, that's not a big deal. But if you've got several inches of adipose tissue between, it can change how accurate that reading is coming back. Ascites is the same idea because you've got more room in between your transducer and the liver and the part that you're trying to measure. And of course, liver masses because they don't act like regular liver. That's the whole problem with liver masses, and so they can give you false results as well. I will also say back in the day when we had to um, when we used transient elastography to measure the amount of damage in the liver to determine whether it was appropriate for them to go on hepatitis C treatment or not, we would often tell people like, oh yeah, this measurement's not looking so good. Why don't you head down to McDonald's down the street, grab a cheeseburger and come back? Because we were trying to get people approved for hepatitis C treatment when we were worried that their insurance company wouldn't be so gracious. Little fun story there. Okay. All right. MR elastography. This is a little bit more of an uncommon test. Typically, the software to do this is proprietary software uh, uh, that some radiologists and radiology centers will have to determine basically how it's the same idea where they're sending MR waves and they're trying to figure out how um, how not jiggly, but how solid the liver is through sending MR waves at it. And basically, you get this picture of this elastogram to get an idea of, what parts are stiffer and what parts are less stiff with doing it. And again, this is usually limited to tertiary care centers just because it is a proprietary thing. This is not something that you're going to get at your, regional ultrasound MRI imaging center down the street. Usually, again, these are really expensive programs that people use. But if you do have option for it, it can be extremely useful and helpful in determining how stiff a liver is. Again, it's also contingent on insurance approval. All right. So just summarizing all the things that we've talked about recently, again, Fib4, like I said, my favorite test. I used to run it on everybody that would walk in through the door just, again, because it puts me in the ballpark. Are we looking at somebody who doesn't have any, they're very unlikely to have advanced fibrosis or cirrhosis? Or is it likely that we have cirrhosis and maybe we need to start looking more detailed at the cirrhosis follow-up and health maintenance? Or do we need more testing to try to figure out what's going on because they fell somewhere in the middle? And then, of course, there's the ELF score, which is, again, that proprietary send-out blood test, and then FibroScan and MRE. All right, so let's go back to Albert. So again, we've got his, again, just going back on him, he is type 2 diabetes, hypertension, hyperlipidemia, no alcohol, BMI of 29, and we want to get some information on him. So again, we know he's got metabolic function associated steatotic liver disease. And again, we know that because he doesn't have any other, all of his other testing was negative. He has no history of alcohol use. Oh, side note that's extremely important, and especially for this case. The only difference between alcohol-related fatty liver disease and metabolic related fatty liver disease is history of alcohol use. That is the main determinant between those two etiologies because they look the same on imaging. They often act very similar. All of their testing for other diseases are going to come up negative too. So it's imperative in patients, especially like Albert, that you get a very, very, very good alcohol history. It's not unreasonable to ask a couple ways because I can't tell you how many times I've asked a patient, do you drink any alcohol? No. Well, do you drink any beer? Yes. Like that, and yeah, anything that you need an ID for counts as a yes to that alcohol question. But people often, when you say alcohol, they will think that you mean hard liquor. And they don't think of like, oh, well, wine. I drink wine. Of course I drink wine. Like, well, no, that was what I asked and you said no. But so that's why you have to get really sometimes very detailed with that question. Like, do you drink anything that you need an ID for is typically how I phrase that question. And then sometimes you get some really cheeky answers like, well, I haven't been carded in 20 years. Like, well, okay, but you know what I mean. So anyways, going on with that. So anyways, remember he's got no alcohol. He's got all these risk factors for metabolic disease. And like we said, we've got this abdominal adiposity, but he doesn't have any stigmata of advanced liver disease. And why I think that knowing that he's got no stigmata of advanced liver disease is because let's just say that you did a test on him that showed that he has almost no fibrosis, but he does have stigmata of advanced liver disease. Obviously, something's not making sense. There, you've got discordant results. You've got to suss that out and figure out which one is more accurate than the other one. So let's see here. Let's figure out what he's got. All right. So these are his labs. We got some LFTs on him. So we see he's got this modest elevation of his ALT. Platelet count is 170. I like that a lot because typically anything over 150, I'm feeling a lot more comfortable with. 150 is like my internal barometer of, is there a chance of having portal hypertension? Let's explain that a little bit. So when the liver gets cirrhotic, with that level of scar tissue or advanced fibrosis even, blood has a harder time getting through it because of the amount of scar tissue. And so what happens is that main portal vein that feeds into the liver, that supplies the liver with 80% of its blood volume, it backs up. And the first place it backs up to is the spleen. And when that happens, the spleen can get big. And when the spleen gets big, it holds on to certain cell lines in the blood more than others. And the very first one that it holds on to are the platelets. So you see sometimes in early cirrhosis, that platelet number starts to drop. And 170, I would have liked to see something closer to 200, but I'll take a 170 because some people just don't make a lot of platelets, but 170, I can be pretty comfortable that it's almost certainly not cirrhosis. His Fib4, oops, his Fib4 is 222. So bonus points for any of you guys who remember what those two intervals are for the Fib4, but for those who don't, I'll bring it up for you again. So again, these are the guidelines for identifying for the Fib4 with basically fatty liver disease. If you've got 2 or more metabolic factors and type 2 diabetes, you're at risk for having fatty liver. And again, if you also, again, our gentleman has steatosis on imaging. So we did a history and laboratory test, and we see his Fib4 right here is 2.22, which puts him right in the middle with indeterminate risk. So we would probably want to do another test to try to figure out where he is on the scale. Is he really at low risk, or is he a high risk patient that is at high risk for having advanced liver disease and steatosis? I'm sorry, fibrosis. Or is he a low risk patient that doesn't have any damage or very minimal damage in his liver, and maybe we need to just keep an eye on it and talk about some lifestyle changes and how we can help protect his liver over time. All right. So I kind of spoiled this one for you. I said he's already an indeterminate risk, and what do you do next? And again, this on here we see already that we need to basically get more testing. Like I said before, all we did right now is a Fib4. We just did basic labs. So we've got a whole array of different things that we can choose from to try to get a different test. I would advise though that um, typically when you are trying to use non-invasive testing and you want to get multiple tests, try not to get them in the same modality. So I would not get a FibroScan or a transient elastography and an MRE because again, they're measuring very similar things. I would want to get a blood test and an imaging or vibration controlled test or something along the lines of that because they have different sensitivities and different specificities and they're measuring different things. And that can make you more confident that whatever you assess the patient to be is more accurate in the end. And the other thing I want to say here too, and I didn't talk about the B word, which in my world is the biopsy, because again, biopsies aren't perfect either. So this whole idea of exactly figuring out exactly how much damage somebody has in the liver is a completely moving target. A biopsy is only 1/50,000th of the liver. So really microscopic piece. And the thing about the biopsy that we found is that it can be highly variable. It depends on who's reading the biopsy, which side of the liver that you're getting it from. We've seen a variation of even an entire fibrosis stage based off of which section of the biopsy you get. And the thing is too, is even with cirrhosis, you can get sampling error. So like if you think about your a cirrhotic nodule, right? And this is my hand right here is like the cirrhotic C nodule, and you're getting a biopsy. If you get a biopsy like that goes like along here, and the needle doesn't go all the way through the capsule, and then you pull it back out, you're only getting a little section of the fibrotic tissue versus like let's say if you go like closer to a section that gets just a lot of scar tissue, and you can get a lot of variance that way. So again, biopsy is the gold standard, but it's a really not good one because it's not very accurate anyways. So again, I feel a lot more comfortable using non-invasive tests to get a good sense of where a patient is on the fibrosis scale. And I've even taken a look at that and compared it to a biopsy. I'm like, yeah, that biopsy is not good. I'm going to go with the non-invasive testing assessment. All right. So we got a FibroScan, and it came up at 6.7 kilopascals, which is considered a low risk. So this is a patient who, again, he's got a lot of risk factors. He's 65. These are things that chances are he's probably going to be okay. We would want to talk about lifestyle modification. So we want to make sure that he probably drops weight. We know that for fatty liver, if you drop around 5% of your mass, that we can actually drive fat out of the liver. And if you drop up to 10%, you can actually reverse any fibrosis that might be there. So I would definitely talk to him very significantly about trying to see what we can do to lose weight. Again, metabolic disease management, and that might even help a lot of that metabolic disease management. And then we would probably want to get a repeat test in a couple of years just to see how he's doing. Is he getting worse? Is he getting better? Was my previous testing accurate? And who knows, maybe in 2 to 3 years, we'll actually have something even better than a FibroScan and Fib4, although I doubt it because they're pretty good tests. So, all right, with that, that was my talk. So I'm happy to open it up to any questions or comments or anything else.